Good morning. I'm Dr. Dangleben, and on behalf of Patient Choice in Chemin, Neuf, Pointe, Michel, this is the medical tidbit of the day. I'm coming off trauma night call, but I figured I did not do too many topics this week, so I'm putting this one out today. I want to talk about myasthenia gravis, something that I don't think is spoken about at all, but it's out there, it exists. And remember, the fact that the diagnosis is not made does not mean that you don't have the disease. It's out there. It's a chronic autoimmune neuromuscular disease, all right? And it causes weakness in your skeletal muscle, right? So your muscles that's required for movement, breathing, and even maintaining your posture, right? So what happens is the immune system mistakenly produces antibodies that interferes with the interaction between the nerve and the muscle, right? So don't want to get too much into the basic science, but it affects what's called acetylcholine receptors at the nerve and the muscle junction that would cause muscle contraction. So it prevents effective muscle contraction, all right? And there's some classic symptoms with myasthenia gravis. Drooping eyelids, right? Coratosis, double vision, difficulty swallowing, difficulty speaking eventually, and weakness in your arms and legs. And the classic example is getting tired if you're brushing your hair, just from brushing your hair. And over time, respiratory difficulty because your breathing muscles are affected, right? It varies in the severity. So mild eye movement to life-threatening breathing weakness. Okay. Diagnosis involves, good questioning of the patient and clinical examination. There's a lot of things that can be done. You could do what's called an EMG, which is an electromyogram, right? There is a tumor in the neck called the thymoma, which is the thymus gland, which is associated with myasthenia gravis also, all right? This treatment is the classic immunosuppressants, the corticosteroids and all the other immune active substances. But the acetylcholinesterase inhibitors, such as physostigmine, pridostigmine, helps improve your muscle contraction, right, by inhibiting the enzyme that would break down acetylcholine at the nerve and the muscle junction, all right? So it's just something I wanted to touch on because it's not something we talk about, but I know it's out there, right? It affects blacks differently than whites or Asians, right? The key distinction is it has an early onset in black patients, all right? And women are more affected, especially in the younger years, in the 20s and the 30s, all right? And it can get worse, right? I'm not saying that if you're tired, getting tired when you brush your hair, you have myasthenia. That's not what I'm saying. It has to be everything placed together and in context to come up with the diagnosis, right? So black patients are more likely black women are more likely to experience severe disease, right? And it can even involve hospitalization and ICU support at some point. Okay, so once the respiratory muscles are involved and you need to be on the ventilator, that's a really significant outcome, right? So just remember that, all right? And the pyridostigmine that I talked about, which is the medication, works in blacks. You want to add some sort of immunosuppressive therapy like the corticosteroids, etc., in addition, for better outcome, okay? So just something I wanted to talk about this morning, so it can be part of our vocabulary. Doctors need to educate their patients on these things, at least work it out, rule it out, right? The other one is Eaton Lambert, which is very similar to myasthenia, but that's a different disease. But we can talk about that some other time. But I just wanted to put that out there this morning. Have a great day. Peace.